Okay, so the first topic we are going to start is gynecology. So in the gynecology, the first topic we are going to start is disorders of menstruation. In the start, every anatomy and everything is discussed. So all you need to do from there is the sidebars. So you can read all the sidebars from there. So the first topic we cannot miss is premenstrual syndrome. It's on the page number 5, if you can go. So premenstrual syndrome is basically physiological and emotional disturbances that occurs 1 to 2 weeks prior to the menses. So you need to know what's the difference between premenstrual syndrome and premenstrual dysphoric syndrome. So what is premenstrual syndrome? The premenstrual syndrome is basically a physiological and emotional disturbances that occur 1 to 2 weeks prior to the menses and last until few days after onset of the menses. Common symptoms include depression, irritability, tearfulness, and mood swings. So synonyms are basically ovarian cycle syndrome or menstrual molemia, which is called basically moodiness. So this includes basically like 1 to 2 symptoms prior, like these started 1 to 2 weeks prior to the menses and last until a few days. So it contains like there it might be the so etiology is basically the causes. So you don't need to know all of those causes, but particularly you need to know some causes, which is very very important. So in this it is already written that this is not complicate completely understood. So like genetic play the role, sometimes the CNS mediated neurotransmitters like serotonin, dopamine, GABA. So these three you need to know. Sometimes they ask in the questions which are the neurotransmitters are affected, or which hormones are affected, or which neurotransmitters play the role in the premenstrual syndrome. Like in a way they ask it, so you get to know like what they're asking. Okay, so then comes the interaction with the sex steroids. What are those sex steroid hormones? Which is basically progesterone, estrogen, and testosterone. Serotonergic dysregulation, currently most plausible theory. So on the side there is like tenor staging. Like you need to know which tenor stage comes after which one. If you know the like it is basically knowing the normal one. If you know the normal, then you can differentiate between the normal from abnormal, right? That's why you need to know which is normal, so you can actually know if they're giving in a scenario what is like not making sense, so you get to know, yeah, this is abnormal and this is normal. So then comes the diagnostic criteria. This is very important because if you know the diagnostic criteria, you can definitely distinguish between the premenstrual dysphoric syndrome and premenstrual syndrome. So what is premenstrual syndrome? At least one affective and one somatic symptom. So what I'm going to do is I'm going to do the differentiation between both, so you get to know what is the difference between it, right? So first we will know what is premenstrual syndrome. So if there is one affective, so one is basically affective. In the second point, it's written effective. What is effectiveness? Like effective, like depression, angry outbursts, irritability, anxiety, confusion, social withdrawal. All these are affective. If any one of them presents along with any somatic related to some body things like having swelling, breast tenderness, bloating, uh, headache, swelling, joint or muscle pain, or the weight loss. So if one comes from the affective and one comes from the somatic, so each need to be exist, right? So if somebody presents with effectiveness and doesn't present with a somatic, you cannot call it as premenstrual syndrome. So both from one from the affective and one from the somatic needs to be there to make it premenstrual syndrome, and it should start 5 days before the menses. This is the exact definition they will tell you. Like a woman came to you, she is 23-year-old, she started having menses at 18 years old or 16 years old whatsoever. So she has angry outbursts just 5 days before the menses, along with she has some like weight loss or maybe some weight gain or some headaches along with it, right? So now you can clearly see they are giving one symptom of affective and one symptom of somatic. So this is basically premenstrual syndrome, and it should be there 5 days before menses. So then next comes symptoms relieved within 4 days of the onset of the menses. So if it starts 5 days before, then it should be relieved 4 days after. She will say that it started like 5 days before the menses or 7 days before the menses, but after 4 days of the menses, it stops. And I have tried a lot of things and it's nothing working for me so far and everything. So you will eventually know that this is premenstrual syndrome, and then it does not occur until the at least day 13 of the cycle. Symptoms present in the absence of any pharmacological therapy, hormonal indigestion, drug, or alcohol use. So if they are not basically using anything. So there's like, oh, it was happening and I didn't try anything, or I was like taking some herbal medications but I haven't tried anything else, and still these symptoms are present. So it should be the absence of no pharmacological use, no hormonal ingestion, no drug or alcohol, because if you use any of these drugs, these symptoms will suppress. Then is basically symptoms occurs reproductively during 2 cycles. Like she will say, I'm having this from last 1 year, I'm having this from last 6 months. So she will eventually know in the last 6 months she might have 6 time menses, right? So in the last 2 cycles she had it, right? So that will make the premenstrual syndrome. Patient suffers from the identical dysfunction in the social and occupational performance. Okay, so what you need to remember from this is it should be one effective, one somatic, 5 days before, 4 days after. It should clear. There is no pain between the 13th day, and within during 2 cycles, she should have these symptoms, and it is affecting her daily life. So these 5 points you need to remember to make it premenstrual syndrome. Now comes the treatment. You don't need to do any investigations because everything clear from the history that this is premenstrual syndrome. You don't need to do any CBC, no need to do any hormonal profile, because it's not like causing any very big disease. It's just she is having this kind of symptoms. So what are you going to do is you are going to prescribe with the non-pharmacological, like behavioral modification first. Everything, anywhere, if they ask for what is the first step you will do, the first step that you need to do is basically behavioral modification. So what comes up as in a behavior modification? Exercise, CBT, and vitamin B6. So this is very important as a first line. So you need to know you can do this anywhere. It is applied in psychiatry. It is applied in anywhere. Like you can write it down anywhere as exercise, CBT, and vitamin B6. Then in the first line, if these things she said, oh yeah, I have been doing exercising and nothing is working out so far, if they have already written this in the history, in the question, so what you need to do next is you can prescribe her combined hormonal contraceptives as far as she doesn't have any contraindications, right? Before prescribing hormonal contraceptives, you have to make sure that she doesn't have any contraindication. But let's suppose if they're asking in MCQs, you can go for combined hormonal contraceptives. Then you can also, if she has some problem with the combined hormonal contraceptives and she cannot take it, so what you can do is you need to you can move on to the next step. What is that? Low dose SSRIs, which is basically prescribed in the luteal phase. So what are the low dose SSRIs, which are citalopram. You will read more in the psychiatry. Then comes, let's suppose she said, I already tried the first line, it's not working for me. What are you going to do next is you can increase the level of the hormonal contraceptives she was using. Now you are going to give the estradiol patches. So what is the difference between combined hormonal contraceptives and the patches? So combined hormonal contraceptives she might be taking in the oral form. Now we are going to do the patches or micronegestrone, IUS, or basically orally or something like that, which is going to give her a full dose continuously, no break in that, right? So she might be taking in a very continuous form. So and the level should be increased, like the dose might be increased, so you can switch to the level up, right? And in the SSRI, if she's taking low dose, then you can move on to the higher doses in the second line. You cannot start in the first line as a high dose. You have to start from the low, then go to high. Then the third line is GnRH analogs and add back hormonal replacement therapy. And the fourth line, if everything stops working for her, she had tried every single thing and is affecting her daily life, she wants to do anything, you can go for surgical treatment. But for that, you have to make sure that she have tried every single thing. Now she doesn't know, or nothing is working for out for her. She's really depressed, and in the very urge of having something to like get to be treated something. So you can go for surgical treatment and HRT. But we don't usually do it for all those women who wants to get pregnant in the future. Then comes this premenstrual dysphoric syndrome. Now you need to know when comes the dysphoric syndrome. So dysphoric syndrome is more like of a psychiatric condition, because this is like more of the mood problem than of the menstrual. It is kind of similar, but has some symptoms more different, because it has more of the severe symptoms which affects his functioning. Like if she is having depression, it might be so severe that she cannot do their daily life activities, so it's affecting really really bad. So clinical features might be irritability, depressed mood, depressed breast pain, and abdominal bloating. So all those things are in a very high level that is affecting like really, really bad. That's why it's become dysphoric syndrome. Dysphoric, like mood, everything is disturbed. So now comes the clinical criteria. Over there, everything was one from the affective and one from somatic. Here, 5 out of the following should be there. Okay? Sorry. During most menstrual cycle of the last year, with at least one of the first four. So in the first four, like depressed mood, anxiety, tension, affective instability, and anger, there should be at least one from these four. So like any one of the psychiatric problem. And then comes is the interest, concentrating, lethargy, appetite, hyperinsomnia, feelings, symptoms, breast tenderness, swelling, hyperactivity. So there might be like more than two. So over there was two, like depression and having this blotting or whatsoever. So here she might have more than two. So all of these, one from the top four, there might be one, and then anything from the bottom. So symptoms usually significant distress, like it's way than that one. So it is very significant distress and interfere with the social or occupational functioning, and must be present with the during the week prior to the menses and resolve within a few days after onset of the menses. So it was basically started like just like that for prior to the week and then resolve within a few days. So it's like that. Must be superimposed on the other psychiatric disorders. So this is the difference. Menstrual syndrome doesn't have anything, but this has superimposed on the psychiatry. She might have underlying already going on a depression, and now she had this thing going on, right? Let's suppose she was an 11-year-old, she already was depressed and having this kind of like conduct disorder or any psychiatric condition going on, and now she start menstruating, and now she start having this problem along with the menses. So now she already particularly have a psychiatric condition, and on top of that she is having this. So this is basically, that's why I'm saying this has more link with the psychiatry, provided it is not merely an exacerbation of the another disorder. So it should be, you should be make sure that this is not a depression that is flared up, or this is not a mania that is flared up, or a bipolar condition that is flared up. It is very differentiating from the depression from this. It's just that depression switched from the depression to this condition now. It's not like that condition flared up. Just like, asthma, it might flared up to acute asthma attack or anything. But that, let's suppose if that asthma particularly changed into a new condition. So this is just like that. That was just an example. So now move on to the next one. We are going to do, it's a page number 7, disorders of menstruation. Amenorrhea, differential diagnosis of amenorrhea. Differential diagnosis, you need to remember all of them. So it is divided into two particularly. First of all, when a patient presents to you, let's suppose we are going to see that that particular person, amenorrhea, is it primary or is it secondary? Let's move on to that cycle. This one, the yellow box, the figure 6 on page number 8. So it is very easy for you to remember from here, and then we can go from there. Let's suppose a patient came to you with amenorrhea. So we have to see it's either primary or either secondary. What is primary? Primary means that she does never have those kind of like stoppage of menstruation before in his whole life, or maybe she never had menstruation any time in his life. So she came to you, she presented, she doesn't have any menstruation, or her mother came to you, she said she doesn't have. So what are you going to do next? The first thing you need to check in that particular patient is either she develops sexual characteristics or not. And if she develops sexual characteristics, right, then she might menstruate within 2 years of that particular sexual characteristics. So if she had sexual characters, yes. And then we are going to do next what? We are going to do, like she said she doesn't have like a sexual characters. Then we are going to check for the hormone level. Might be she's having FSH low, that's why she doesn't develop her breast, she doesn't have those like pubic hairs or axillary hairs. So we are going to check for the hormone level. But if she particularly have the sexual characters, like some might be there, some might not be there, so what are you going to do is you're going to do for the karyotyping. So on the karyotyping, you find out it's either XX or either XY. There's no third thing. If she's XX, definitely she's going to be a female. So what are we going to see is now she's female and she has a sexual characters, and now she's not menstruating. There might be some underlying pathology going on. So what are we going to do is ultrasound, see, like from the transabdominal ultrasound, or we are going to do examination or stuff like that, to see what particularly is affected into that particular area. Because the rest of the things are going okay, like she had breasts, she has axillary hairs, but now she doesn't have those uterus, like she's not menstruating, sorry. At this particular point we cannot say what is going on. So particularly maybe that uh, sorry, okay, so might be particularly at that particular point that particular organ is affected. So what are we going to do is, it's like we're going to check for that, either maybe the hymen inside is imperforated, transverse vaginal septum, cervical agenesis, Mullerian agenesis. These things you will read when the in the pediatrics more about these things. So what happened is basically cervical agenesis, like cervical is not properly formed. Mullerian agenesis, like inside uterus is not formed. Transverse vaginal septum, there is like a vaginal septum which is divided into two, and then imperforated hymen. The hymen is not like perforated properly. So then comes is XY. Let's suppose if that we do the karyotyping, we do XY. XY is basically androgen insensitivity syndrome, right? So might be androgens is not working properly. And then if secondary sexual characteristics, no, then FSH and LH. If FSH is high, then we go for hypergonadotropin. If low is hypogonadotropin. Hypergonadotropin might be the cause is gonadal agenesis, like gonads are not working. So that's why hypergonadotropin, like GnRH is very high, but the gonad is not working properly. Then if either GnRH is very low, that's why the constitutional delay, or HPOX is like might be the brain is not working properly. That's why GnRH is very low, because GnRH is coming from your brain. Then comes the secondary. Like secondary, that particular female already had menses, but now there is particular time that she is not menstruating. So first thing that you need to rule out, regardless of anything, if that person is presenting to you with the secondary amenorrhea, you need to rule out pregnancy until proven otherwise. This is a clear cut statement. Any person who presented to you with she said like she doesn't have menses for last particular days, and she already had menses in the past life and now she's coming, so first thing you need to do is beta hcg, and it's positive, pregnancy. There you go. If not positive, then you go for the next step, prolactin. Prolactin is abnormal, then might be prolactinoma. Prolactin level is high. If prolactin level is more than 100, then you go for CT scan. You need to see if there is any tumor inside the brain. TSH to screen for the hypothyroidism, maybe pituitary adenoma or something going on. Then prolactin. Prolactin level is normal. Then we go for progesterone challenge. Progesterone challenge, what we do here is we give the progesterone and see if that particular female bleeds or not. So what we particularly do is, when we do amenorrhea, secondary amenorrhea women come, then the first time we do is beta HCG. Then instead of going directly to the prolactin, we go for progesterone first. Progesterone challenge. A lot of things are ruled out from progesterone challenge. But if that particular female is saying that she has a nipple discharge or something, then we definitely go for the prolactin. But sometimes we don't go for the prolactin because it's very rare that somebody has prolactinoma going on. Okay, then we go for the progesterone challenge. If that particularly woman doesn't bleed, then it means that she is having primary ovarian insufficiency, because if ovaries are not working properly, then how can progesterone work properly, right? So that's why progesterone challenge is not working over there. Progesterone challenge means if she is coming as you are giving progesterone and she doesn't bleed, then it means it's a negative. Then either maybe Asherman syndrome, she might be having some Asherman syndrome, like any adhesions formation in the uterus, or maybe uterine defect, or HPO axis dysfunction, maybe some from the brain, hypothalamus to pituitary to the ovarian, there is some axis maybe disturbed. Then comes the withdrawal bleed. If that progesterone, after giving progesterone, that there is a withdrawal bleed, then we do is LH and FSH challenge. If that is high, then we give PCOS, hyperandrogenism. If it's normal or low, then we do HPO axis dysfunction, MRI, hypothalamus, pituitary. There might be the problem, might be over there. Like maybe she had lost weight too aggressively, that particular thing affected her menstruation. Maybe she is exercising too aggressively, that particular thing is affecting her menstruation. Maybe any systemic disease like rheumatoid arthritis or SLE, that is causing this amenorrhea. So you have to know all of these things step by step to rule out particular things, because if you do all of these step by step, you get to know a lot of stuff. So you need to remember it by heart. So like that. Now it would be very easy for you to go up and see these table 2 and table 3. So you have to remember it by yourself. I am just going to read it, but this is no point of doing that, so you can just read it quickly. So on the side is most common causes of the primary amenorrhea is basically Mullerian agenesis. You cannot miss if somebody comes from the primary amenorrhea, a Mullerian agenesis. You have to think of that first. Then comes this abnormal sex chromosomes, which is Turner syndrome. Then the functional hypothalamic amenorrhea. Then is functional hypothalamic amenorrhea is the most common cause of the secondary amenorrhea. Obviously, secondary amenorrhea, you have to rule out pregnancy. But if, let's suppose you think of pregnancy and you already rule out, then the next step you think is she might be doing something aggressively. That's why she's causing maybe weight loss, maybe exercise. So you have to rule out these things. It's very easy to and common things to rule out. And then might be investigations, all these investigations one by one, which is written here. You can do beta HCG, prolactin, progesterone challenge, LHS, LH, FSH, and then PCOS you have to see, karyotyping, FSH, and LH on the basis of that particular person, how she's presenting and at what level she's presenting. So you go for that particular thing and then you see, and in sometimes you have to go for ultrasound directly without doing anything. Maybe you see she's presenting with the typical features of PCOS. So you don't have to do all this you can do beta HCG, you can, it's very easy to do, but you cannot do karyotyping or you cannot do progesterone. That doesn't make sense. You just directly jump to ultrasound and rule out, oh, this is PCOS, now I have to do the treatment. If you do progesterone and everything, you are just doing something which is useless. Then comes this prolactinoma syndrome, galactorrhea, visual changes, and headache. Then comes the treatment. In the AIS, like androgen sensitivity syndrome and Mullerian agenesis, we do the same thing. First of all, we start with the psychological counseling. Then we do gonadal resection in the AIS after puberty and the creation of the new vagina. In the Mullerian agenesis, we have to create the new vagina with dilation because there is no vagina and there is no uterus. So on the basis of what patient's priorities, what she wants or what he wants, we can go along with that. So diagnostic study to confirm normal uterine system. It's very important. I saw one MCQs where they were asking if somebody presented with a Mullerian agenesis, what are we going to do next to rule out? So the next thing you need to rule out is urinary system. You need to check out if her urinary system is normal or not. Sometimes what happens is that uterus is not formed, so kidneys are also not formed so properly, because that is also urinary system and the reproductive system is very close by. That's why. Then comes in perforated hymen, transverse. They all do surgical management, cervical agenesis, you do suppression, and ultimately hysterectomy. In secondary amenorrhea, you have to rule out is the hyperprolactinemia, HPO axis dysfunction, PCOS, primary ovarian failure, or uterine defect, and Asherman syndrome. In HPO axis, you have to see the underlying cause. You do osteoporosis for the osteoporosis, for the maintaining of normal vagina, you have to prescribe OCPs. Hyperprolactinemia, you do MRI, CT to rule out if there is any tumor going on. If no demonstrated, then MRI, bromocriptine, cabergoline used for the hyperprolactinemia. Either gives OCPs and then MRI, and if needed, surgical resection. And primary ovarian failure, you need to rule out other, autosomal diseases, sorry, autoimmune diseases, diabetes mellitus, hypothyroidism, hypoparathyroidism, hypercortisolism, and hormonal therapy. In the uterine defect, you have to do hysterosalpingography to rule out if there is any like underlying pathology going on, or it's very normal. So this is the definition which we already talked about, primary amenorrhea and secondary amenorrhea. In the primary amenorrhea, no menses by the 13 in the absence of the secondary sexual characters, like no secondary sexual characters is 13. So you have to see if it's the primary amenorrhea, or the no menses by the 15, but the secondary sexual characteristics are the no menses second year after thelarchy. So secondary amenorrhea is basically no menses for more than 6 months. If somebody is coming with a 2 months or 3 months, it's totally fine. You have to reassure her and ask her to come back again. Secondary amenorrhea is pregnancy until proven otherwise.